Da Vinci Health.
Hello and welcome to another episode of the Synapse eLearning series. With us today we have Mr. Caruana Dingli, Gordon Caruana Dingli. Thank you for accepting our invitation and being here today. Gordon Caruana Dingli graduated as a medical practitioner in Malta in 1984. He trained in surgery in Malta, Italy and the UK and is a fellow of the Royal Colleges of Surgeons of Edinburgh and Glasgow. He is a consultant surgeon, a deputy chairman of the Department of Surgery and the head of the breast unit at Mater Dei. And Mr. Caruana Dingli is also a senior lecturer and president of the Medical Association of Malta. He's also immediate past president of the Association of Surgeons of Malta and the Commonwealth Medical Association. Mr. Caruana Dingli, today we'll be speaking about the management of breast cancer. How has the management of breast cancer developed over the last few years?
First of all, thank you very much for the invitation. I'm very pleased to come here today. Breast cancer has evolved a lot over the years. There's a lot of research being done in the field, a lot of investment. And if we look back historically to the times of Halsted, when radical mastectomy used to be performed, this involved removing the muscles of the chest wall besides the breast, and they were even considering removing the upper limb, the arm, at the time of surgery. Over the years, there have been a lot of changes, and even in the time of my career, I have seen some major changes. When I started working as a doctor, most people with breast cancer had a mastectomy, and very often this was in combination with a frozen section, which means that a sample was taken at the time, and the pathologist, under a lot of pressure, would have to give the diagnosis and tell us whether this was malignant or not, and then we would proceed for mastectomy. This was rather cruel for the patients because they would often wake up and feel their chest to see whether the breast was still there. Over the years, we started doing what we call FNAs, which are fine needle aspiration cytology, which is a very simple test, and it gives you a result very quickly to confirm whether a particular lump is malignant or not. Again, this has now been superseded by what we call core biopsies, where we take an actual piece of tissue for histology, and this is usually done by under ultrasound control by a radiologist rather than by the surgeon. Even in the field of investigations, there have been some dramatic improvements in mammography, which is now digital, and this doesn't only cut down on wastage of silver in the films, but it also gives a much clearer image with less radiation, which is important. Ultrasound machines are now fantastic compared to what they used to be in the past. They are so much more sophisticated, and the radiologist can actually see the needle of a biopsy going into a lump, and they can be sure that they are taking the biopsy of the appropriate part. And we're also using MRI. MRI is a very useful investigation in breast cancer, and we use it under certain conditions, in certain situations.
As we well know, the breast care unit is central in the management of breast cancer and the detection of breast cancer. But why do we need such a multidisciplinary approach?
I'm glad you're asking me this question, because this year, 2015, happens to be the 15th anniversary of the setting up of the breast clinic with the multidisciplinary team. I'm very proud to have been involved from the very beginning, and I think this is the team that has been running the longest at the hospital. It's really a meeting which we have once a week, where there are surgeons, pathologists, radiologists, oncologists, breast care nurses, and we all meet up and discuss our patients. Sometimes we discuss 40 patients in a session, and it is useful because we help each other with each other's expertise to give the best possible treatment we can to a particular patient. There are some other advantages too, because we get to know each other very well, and we can contact each other very easily and to discuss patients when there's a problem. And this allows us to try and give the best possible treatment to our patients. But best possible treatment does not only involve best treatment from the aspect of tumor or cancer clearance, but it's also important to think of the psychology of the patient and her family and friends. And one major factor in this is the cosmetic outcome of surgery. whilst in the past many patients would get a mastectomy, now only about 30% have a mastectomy, and many of these are then have a reconstruction, either at the time of mastectomy or delayed later on. But we're also practicing what we call oncoplastic surgery. And this means that we do the breast surgery, a wide local excision, with plastic surgery techniques. So we plan the incision, we mobilize the glands of the breast to try and improve the outcome as much as possible, and to try and give the best possible psychological outcome from following surgery. One breast surgeon that's a friend of mine, a British breast surgeon, tells me patients coming to me with breast cancer go out with better looking breasts than they did before they came to the operation. And I think we have to realize how important the cosmetic outcome is to a lady.
Undoubtedly, you've mentioned the interaction between different medical professionals from all fields into a final good outcome for the patient. What can you comment about the interaction between surgeons and oncologists, and how has it developed over time?
We discuss all patients together, so we get used to what the oncologists want, and the oncologists also are very aware of the type of surgery we do. And by having these meetings, we improve the results, because we work. We have the advantage of using the expertise of both fields, not just one person doing things on his own.
And undoubtedly, this interaction also helps with the use of possibly new medication, chemotherapeutic agents. What can you comment about the future developments, possibly the recent future, the upcoming future, with regards to the chemotherapeutic agents in breast cancer?
The first breakthrough, really medical breakthrough in breast cancer, was tamoxifen. This was first used in the late 70s. A lot of work was done by Professor Michael Baum at the Royal Marsden, who I've worked with. And this translated into the use of this drug, which is really quite a simple tablet once a day, gave a 15% improvement on mortality. That was the first big breakthrough. Chemotherapy is being used for many years, and it's improved a lot. There are newer drugs. But I think one of the main advantages is that there's much better control of the side effects. There are modern medicines like antiemetics, the use of steroids, which make it less uncomfortable for the patient, because chemotherapy is quite a traumatic experience for a lady. And now, more recently, there's the breakthrough of monoclonal antibodies, which are targeted treatments, which are effective in certain situations. They are more targeted because they do more harm to the diseased cell, to the cancer cell, than the rest of the body. One of them in particular is Herceptin. Many people have heard of Herceptin. This is now available on the NHS, and it's used in patients who have a receptor for this HER2 receptor. Now there's been another development where the Herceptin carries a very toxic chemical which cannot be used on its own because it's too toxic, but the Herceptin delivers it into the cell, drops it in the cell, and then it damages the diseased cell. I think this is a great breakthrough. There have been other modern drugs like everolimus, but this is very much the province of the oncologists. Whilst we're aware of these and the oncologists discuss it with them, they only prescribed and administered by the oncologist, so they have the expertise for it.
And Mr. Caruana Dingli, we're discussing the treatment, the cure for breast cancer, with the surgical, oncological, multidisciplinary in nature. But on the other side of the line now, prevention. What can you say about screening, modern screening programs right now here in Malta?
In principle, screening is early detection rather than prevention in breast, because the aim of taking a mammogram in patients who have no symptoms is to try and catch the tumor at a stage when it's small and more easily treated, less aggressive surgery, less aggressive chemotherapy, with the aim of a higher rate of cure. That's the principle of screening mammograms. In other fields, screening can be preventive. For example, in colon, if you detect a colonic polyp before it has become a cancer, you have prevented the disease. One could argue that if you detect what we call DCIS, which is ductal carcinoma in situ, with mammography, before it has become an invasive cancer, by screening we might prevent the incidence of invasive cancers. What is on the horizon is always difficult to say. It's always difficult to predict the future. It's quite a dangerous occupation to predict the future. But one would hope, and there is a lot of work being done on some form of vaccine, which would prevent the disease. Once you mentioned prevention, I suppose I should mention preventive surgery. There's a subset of ladies who have an oncogene, BRCA1 or 2, and this can be detected by a simple blood test after counseling by a geneticist. And women who have this oncogene have a very high possibility of getting the disease. Something like 80% of these women will develop breast cancer at a young age. And for this small group of women, we offer preventive surgery, which involves removing the breast tissue and leaving behind the skin, some subcutaneous tissue and the nipple and the areola, and replacing it with an implant. And this then does not remove the risk of breast cancer, because you only remove 95% of breast tissue, you can't remove 100%. But of course, the risk of getting breast cancer is very substantially less than 80%. We've been doing these operations for some time, very often in combination with our colleagues, plastic surgeons. And a few years ago, this has achieved a lot of attention because a famous actress, Angelina Jolie, had this problem and had this operation. So we often get women coming to clinic asking for the Angelina Jolie operation, and we understand exactly what they're talking about. But of course, this is not something that we would advise to normal women, not something we can do indiscriminately, but only those that have a particularly high chance or risk, I should say, of getting breast cancer.
Undoubtedly, some of the medical professionals who are watching this episode encounter patients who are reluctant in participating in screening programs because of the fear of false positive results. What can you comment about that?
That's another good question, because there is a definite risk of false positive. So a lady would go for a screen mammogram, and of course she hopes that she'll be told everything is all right. A few will be told that they have some suspicious lesion, and then they will need more testing, more either an ultrasound, biopsy. And some of these will have all these tests, and then they'll be told that there was nothing wrong after all. And this can cause a lot of psychological problems. So this, if you like, is the cost that some women will undergo without getting any benefit, for some other women who would get the benefit of early detection. Mammography is not the perfect screening tool. It's the best we have, but it will miss some tumors and it will overdiagnose some other ladies who don't have a tumor.
Early detection of breast cancer, and this will be my last question, depends on a number of factors. One of them is obviously imaging, as you rightly said, and also biopsy, but there's also the clinical examination in itself. Now, I believe that some medical professionals may encounter breast lumps in different age groups. What should be the threshold for a referral to the breast clinic?
You're absolutely right that, for example, gynecologists and general practitioners often offer breast examination to the patients who might present with some other problem. And many women also self-examine, and we encourage this. It's something quite easy to do and harmless, and then both general practitioners and patients would feel something suspicious, and they will come to the doctor, and the doctor might pick it up himself, and they need to decide whether this is something which is not worrying and can be followed up by the general practitioner, or whether they should be referred to a specialist centre for further investigation. I think the age is important, and breast cancer, even though it can occur in young women, is more common in the elder women. Certain symptoms are obvious. I think if it's a hard lump, if there's skin tethering, if there's bleeding from the nipple, or if the signs of metastasis. Some women present with a fracture or with jaundice because of metastasis to bone or to liver. Some others present with shortness of breath because they have lung mets. These, of course, have to be dealt with at the hospital, where we do the investigations, and then we can advise on further treatment. I'm pleased that you asked me to come along this year, because it's our anniversary year, 15th anniversary of setting up the breast clinic, and we are planning a seminar in October where we have certain new developments which we'll be launching then. One of these is launching an online referral form for GPs, where they'll be able to instantly refer patients to the hospital. We're going to launch guidelines, protocols, and also patient information leaflets, so watch the space.
And on that positive note, we conclude this episode. Thank you, Mr. Caruana Dingli, for your time. We hope that his input has helped to further clear your understanding on the subject, and we invite you to share this video with your professional colleagues.
Did you know that breast cancer is the most common form of cancer diagnosed in Maltese women? If detected early, breast cancer may be curable in 98% of cases. The best way to ensure that breast cancer is detected in its earliest, most treatable stage is to practice monthly self-examination. The National Cancer Institute of America also recommends that women over 40 should have yearly mammograms, or at the very least bi-yearly. At Da Vinci Health, we offer full-field digital mammograms. These are more accurate than any other digital mammogram and are today's gold standard. We offer a personal and timely experience where your test results will be communicated immediately and on a one-to-one basis. Early detection can save your life. Your peace of mind is just a phone call away. 2149 1200.